Greetings from Bilmed. Myself, Dr. A.B. Wani, Director of CEO of Bilmed Group of Institutions. Today, we have invited Dr. Gunjan Goel. Namaste. She is a gynecologist. What we will discuss today, that many a times, the gynecologist is scanning. Gynecologists do have knowledge of ultrasound because the ultrasound is in the curriculum of gynae obs. So, whenever you are putting a probe on the fetal head to measure a BPD or a head circumference, which you have to, you are seeing automatically popping up is the fetal brain. And if there is something abnormal, you get puzzled. You don't know what to do next, which patient to refer, and whether this is actually a normal or an abnormal case. Am I right, ma'am?
Yes, sir.
Now, tell me what type of, what are the challenges when you are putting a probe onto the fetal head? Because you have to put a probe on the fetal head and you don't have, for example, for the sake of argument, you have not undergone a training in ultrasound. But what you are doing, you are trying to take a fetal BPD. You know how to take it. That is the kid's job. But the point is, this is the fetal head over here. You are trying to take a BPD, but there are a lot of things which are automatically popping up on the ultrasound screen. And if there is any abnormality over here, first of all, you are not very much aware of whether this is abnormal or not. So tell me the challenge and the difficulties what you are facing over there.
Sir, whenever we are doing an ultrasound or basic scan, and when the BPD is not falling in reference values, how should we approach it?
Okay, so the question number first is that you are having a gestational age of, you are expecting a gestational age as per the biparietal diameter, because you know the LMP, that is 32 weeks. You are expecting a 32 weeks biparietal diameter or a head circumference, which you have to measure. Now, all of a sudden, the BPD is not 32 weeks, but it is 36 weeks. This is your question.
This is my
What
question.
to do next?
What to do next? How
Now,
to approach?
First of all, we have to understand that if there is Ram and Sham, is the head perimetry same of Ram and Sham, and Ram or Sham are twins, identical twins.
Okay.
The chorionicity, amnioticity, same. Okay, monozygotic. Okay. Now, tell me honestly, is the head perimetry of Ram, who is 7 years or 70 years, is it same of the Sham? No. Now, first of all, we have to understand, when you are taking a BPD, you will not expect it to have same in each and every fetus. That is why we are having standard SDs, deviations, plus minus 10. Now, this 36 can be normal, but can be abnormal also. You have to understand. Because if there is another example, if there is a 14 years or a 24, let's take 24 years, a normal person from China and a normal person of same age group from South Korea, from South Africa, I will say. Will they be same height-wise? No. So why you are expecting each and every fetus in utero to be of the same 32 weeks?
Okay.
Your machine is calculating, for example, 88 millimeters. For example, this is not, but for example, if 88 machine is born blind, if 88 millimeters is corresponding to 32 weeks, this 88 can be more, try to understand, can be more. In a South African, it can be 92 millimeters, for example. And this 92 millimeters, when given to machine, will it show 32 weeks more or less?
Less.
Try to understand. 88 is corresponding to 32 weeks.
Okay.
But you are now scanning a South African patient. There it is 92. Will you expect this 32 increase, decrease, or remain same?
Increased.
Increase. Maybe. Now try to understand. Maybe this 36 is due to that you are having a big fetal head, and that big fetal head is due to the constitution of that fetus. That is one. Second, will there be not the possibility that there is something which is making this head? Now, this is not the cause. For example, first cause is this. Now, second, is it not possible that something is increasing the intracranial pressure? Try to understand. Something which we will discuss. And if I am having something which is increasing the fetal intracranial pressure, will this biparatal diameter, whatever you are measuring, will it be more, less, or remain same if the intracranial pressure is increased?
It will be more.
It will be more. So first of all, you have to keep in mind that there are some standard deviation, number one. Number second, maybe that there is something which is causing the intracranial pressure to increase. Now, let's discuss what that something can be.
What are the most common intracranial anomalies which we suspect in abnormal BPD?
Now, in abnormal BPDs, there can be ventriculomegaly.
Okay.
Now, in ventriculomegaly, now try to understand, in ventriculomegaly, if I am having increased ventricles, both lateral ventricles, what will be the overall BPD?
It will be increased.
Increased. So this 36, second possibility is due to the increased intracranial pressure, which is due to the ventriculomegaly. Now, question. Now I am posing you: are you doing ultrasounds? This much detailed ultrasound, or you are merely taking the biparatal diameter?
We are somehow grossly doing all the details scans in last trimester or so.
Also, now if you see a ventricle first and ventricle second, this is the right and this is the left one. Both are dilated. What the cause can be? What next do you have to see? We will come to the cause. What next do you have to see? Bilateral lateral ventricles are dilated, and this 36 is due to this now. What next do you have to do?
I think we should see for third ventricle.
Third ventricle. Now here comes the role of the anatomy. Now try to understand. This ultrasound is not about, all the photos, all the pictures, clips, hands-on. No. You have to play with your neurons. You have to put your brain in the machine, then all the machine will work. Okay. Now, if both the lateral ventricles are dilated, you will see this very clearly when you are taking an axial section, a BPD wala plane. Now, where is the third ventricle? Tell me, you think?
Sir, third ventricle is like in the hindbrain.
Now here. Where is the third ventricle? Try to understand. This is an axial section of the brain. Now you have to be aware of the axial and these coronal sections. This is where the training part comes in. Now, why is the third ventricle over here? In your BPD wala plane, I'm giving you options. Is it here? Yes or no?
No.
Is it here? Yes or no?
No, sir.
Is it here? Yes or no?
No, sir.
Is it here? Yes or no?
Yes, sir.
No, it is not there. So now see, both the lateral ventricles are draining in the third ventricle. Why the third ventricle has to be in this plane? In the center or away from the center?
It should be away from the center.
Now I am repeating my statement. Both the lateral ventricles have to drain in the third ventricle.
It should be in the center.
Right. So it has to be in the center. It has to be in the center only because the both lateral ventricles has to drain over there. So it is over there.
Okay.
Question. Are you seeing third ventricle in each and every patient? I mean, in each and every fetus? No. Whenever you are putting a probe. Now, I am again repeating my statement. This ultrasound is all about the theory. I will say all about the theory, 99% the theory. People are thinking that this is all about practicals. This is the catch here. No. Are you seeing something round in the center? When you are taking a BPD, are you seeing something round like there? You are not.
No, we are not.
You are not. It means this third ventricle, now this is third ventricle. This third ventricle is not seen. And if seen, it is dilated. Now the point is, first ventricle dilated. Now it will look like a kid's job now. But the point here is that if you are not knowing all this sonoanatomy, you will never be able to do a good ultrasound. Never. First ventricle dilated, let's sort out. Second ventricle also dilated. You can see it when taking a BPD wala plate, and you can see a round cystic-like structure in the center and the thalami. This is third ventricle, and I am repeating, if dilated, it will be seen, and if it is not dilated, it is not seen at all.
Okay.
First and second ventricle you are seeing normally.
Okay.
Without any dilatation. But third ventricle, if seen, is dilated. Clear?
Clear.
Now, this third ventricle has to drain. Recall the anatomy. See how important the anatomy is. This third ventricle has to drain into fourth ventricle. Now, where is the fourth ventricle? Now, try to understand. Where is the fourth ventricle? Fourth ventricle is here. This is the fourth ventricle. This fourth ventricle, third ventricle will drain in the fourth ventricle. Right? Let's stop over here only in this session. This is a small session. We are not right now taking any course. We are giving you a demo. I am trying to give you a demo how important the knowledge is. I mean the theoretical knowledge. Then only you can do a good ultrasound. Now, this ventricle and this ventricle is connecting with the third ventricle by some, foramen of Monroe's over there. Let's not discuss that because that will take time. Now, if obstruction, now try to understand. If obstruction is here, see where I am. Between the third and the fourth ventricle, over here. This is obstructed over here. What first this is? What is the connection between the third and the fourth ventricle called? Aqueduct of Sylvius. Now you are recalling from the MB second or maybe a first year only. These points are very important. Now this is the aqueduct of Sylvius which is obstructed over here. What all will be dilated? Because I am having here choroid plexus, which is the factory of cerebrospinal fluid. This is continuing excreting the cerebrospinal fluid. Where the cerebrospinal fluid will pull up, I am using word. If I am having obstruction over here, now you tell me the ultrasound findings. I am repeating, Dr. Gunjan. You will tell me now the ultrasound findings in case of an aqueductal stenosis here, while taking a simple BPD plate.
See, when the aqueduct of Sylvius is obstructed, as per our discussion, we can make out both the dilated lateral ventricles and dilated third ventricle also, and choroid plexus cyst also I can see if possible, and there will be abnormal BPD also.
Very good. Not the choroid plexus cyst. Choroid plexus cyst is having no association with the hydrocephalus. Now, you have come up with the sonographic the findings in case of an aqueductal stenosis, that is both lateral ventricles dilated, both, but third ventricle also dilated. I didn't tell you, no? You told me these things. Why you were able to? Because I told you anatomy.
Okay.
Now, question again. Next question. What will be the status of fourth ventricle in case of aqueductal stenosis? Will it be normal or dilated? Think first. Repeating the question. What will be the status of fourth ventricle? And see here where the fourth ventricle is. What will be the status of the fourth ventricle in case of aqueductal stenosis? Stenosis is here. My factory for excreting the CSF is over here. What will be the status of fourth ventricle in case of aqueductal stenosis?
It will not be dilated.
Very good. It will not be dilated. Now you are giving me all the sonographic findings. Why now you are giving me? Why before you were not be? Because first of all, I gave you the sonoanatomy. This is the sonoanatomy.
Okay.
Now another proof. Another proof of knowing the sonoanatomy and decoding the ultrasound language. Now the point here is that if fourth ventricle is dilated, now try to understand. If fourth ventricle is dilated, First of all, let's clear. Can that be the aqueductal stenosis? Yes or no?
No.
No. Where is the obstruction then?
After
Lower down.
Lower down.
Lower down. So it can be. Where is the cisterna magna over here? This is cerebellum. Cisterna magna is here. This is spine over here. So now if all the lateral, both the lateral ventricles along with third ventricle and fourth ventricle is dilated, where is the, obstruction?
Okay. After the fourth ventricle obstruction, most probably here.
Most probably here, right? Now over here, I am having fourth ventricle. Fourth ventricle is draining in the cisterna magna along with the subarachnoid spaces. We are having apertures over here. We will not discuss these apertures. If I am having at these apertures any problem, or if I am having something abnormal in spine, if something abnormal in spine, and I am having both lateral ventricles dilated, third ventricle, fourth ventricle dilated, and some abnormalities in spine, which is telling on the brain. Is that not possible?
That is very much possible.
That is very much possible. Now, what that in spine can be? Spina bifida.
Okay.
So if there is a defect in the spine and the brain is reflecting this, what we have discussed, what is that called as? That pathology. You will not even imagine that you have diagnosed that pathology. No. Think. Have you heard of a cherry second malformation?
Okay.
Now see, the cherry second malformation, when I am talking of the cherry second malformation, it looks like I am a gynecologist. What I have to do with these high-end, pathologies? Now you have diagnosed, not me. Now you have diagnosed the cherry second malformation.
Okay.
So what is the cherry second malformation? If there is a defect in spine, along with all what we have discussed in the brain. Now, cleaning all. Now, whenever you will be putting a probe for what? To measure a biparietal diameter. It is not that only the biparietal diameter will pop up over here. You will be seeing some brain structures over here, and if abnormal these structures, you will get puzzled.
Okay.
You will start referring this here and there. Why to refer? The point is why to refer. Why you cannot do this? Is this radiologist having two horns over here? No. He is also thinking by his brain, and you are also having a brain. Let's start working with the brain. Ultrasound is not about photography. It is the real test of our neurons. So have some basic training first and go through the books. Training is very important over here. So go to any institute, but have a basic training over here. Then you can do wonders with this ultrasound. You are already having a PNDT registration. You are having a clinic. You are having patients. You are having a high-end machine. Maybe that radiologist is having a lower-end machine. But you are not able to use that machine because you are not spending some time on to yourself for upgradation. In West, everybody is upgrading himself or herself. And here, what we are thinking, I am already having a post-graduation in this and that, and this post-graduation has been completed some 10 years before, and these books and this upgradation is now closed. So, the moral of the story is that go to any institute, have some basic training, and you can do wonders with this ultrasound. Okay.
Thank you so much, sir. That was very impressive presentation, and that gave me a very good insight of biparietal diameter, short anatomy of brain, and how to diagnose the difficult brain anomalies. And that was really eye opener for me, and I will go more into it. And that was really very, very good. Thank you, Bilman. Thank you, sir.
Thank you, madam. Thank you. God bless.